Hello everyone, welcome to today's quarantine clinic. Today we are discussing neuromuscular junction and we are discussing myasthenia gravis. So this is the first time that we are discussing the neuromuscular junction, and the neuromuscular junction is, as the name suggests, it is the junction that lies between the nerve and the muscle. So if we take the overall neuroanatomy, you remember that there is UMN and LMN, and your UMN goes from your cortex, your brainstem, and your spinal cord, and your LMN comes from after after we leave the spinal cord. You enter the roots, the plexus, the nerves, and then you enter the neuromuscular junction, and finally the muscle. So today we are discussing only this, the junction between the nerve and the muscle. So what happens here? Now, in the neuromuscular junction, there is basically a nerve ending and there is the surface of the muscle. So this is the nerve ending and this is the muscle. And the function of the neuromuscular junction is to convey the signal that your brain sends down the spinal cord all the way to the nerve that this muscle has to contract. So the function of the neuromuscular junction is to convey the signal from the nerve ending to the muscle so that ultimately the muscle contracts. So this is the purpose. And so let's first talk about the anatomy and the physiology of the neuromuscular junction. If your nerve has to communicate with the muscle, it has to communicate via some way. Now, there are only two ways of communication in the body. One is electric and the other is chemical. Now, the electric form of communication is there from the brain to the nerve ending. So till here, most of it is electric, but every time you come across a gap, which is known as synapse, that gap has to be crossed over by some chemical. And these chemicals are known as neurotransmitters. So every time there is a gap, a neurotransmitter will carry the signal across. And then if the signal is carried across from nerve to nerve, then there is electricity, there is chemical, and then again there is an electric current. But in this case, the signal is getting transported from a nerve to a muscle. So then there will be electricity, chemical, and then muscle contraction. So what is the neurotransmitter across a neuromuscular junction? It is known as acetylcholine. So there will be an electric signal that comes along the nerve, and at the end of the nerve, you have your release of acetylcholine chemical. This acetylcholine will somehow enter the muscle fiber and ultimately cause contraction. This is the function of the neuromuscular junction. Now let's look at it in a little bit more detail as to how does it do it. So this is the presynaptic terminal. Why is it presynaptic? Because between the muscle and the nerve, this area, this entire area is known as synapse. So anything that is before this area becomes presynapse, anything that is after this area becomes postsynapse. So this is the presynaptic nerve terminal. This is the synapse. And then you have your postsynaptic muscle membrane. Now here I drew the muscle membrane as straight, but in reality, the muscle membrane is actually like this. Okay. So this is the muscle membrane, and this is known as postsynaptic synaptic membrane. So you have a presynaptic terminal, the synapse, and the postsynaptic membrane. Now in the nerve, your electric current has come till here, carrying the signal. And this electric current has to talk to this membrane. So it will cause the release of acetylcholine. So there are multiple acetylcholine molecules that are released. Now, how are they released? In the presynaptic terminal, acetylcholine is stored inside these small structures known as vesicles. So there are a lot of vesicles that are stored inside the presynaptic terminal. And when you get a signal saying that this muscle has to be activated, these acetylcholine vesicles will move to the edge of the membrane. It will fuse with the membrane and then release the acetylcholine molecules. And what causes these acetylcholine vesicles to merge with the membrane? There is calcium inside the presynaptic terminal. So your calcium is what causes these acetylcholine vesicles to release the acetylcholine outside. So far, what do we know? You have a nerve signal. That nerve signal causes increased calcium entry into the presynapse. And this calcium causes acetylcholine release. So now we have covered step 1. So this is step 1 of understanding your neuromuscular junction, that your electric signal will cause increased calcium. That increased calcium will cause the release of acetylcholine. Now we come to step 2. What happens in the synapse? In the synapse, your acetylcholine molecules will move towards your postsynaptic membrane. Now, in your postsynaptic membrane, there is something that should be ready to receive these acetylcholine molecules. And conveniently, there are just that thing. These are known as acetylcholine receptors. Now, acetylcholine receptors are proteins that are designed to allow the acetylcholine to exactly fit into the acetylcholine receptor. And once they fit into the receptor, these receptors will go on to ultimately cause muscle contraction. How does it do that? We'll discuss that in a minute. But for now, these acetylcholine molecules who are in the synapse will go and attach themselves to the acetylcholine receptors in the postsynaptic membrane. What happens to the acetylcholine molecules after that? The remaining acetylcholine molecules are then degraded into acetyl and choline. And this happens via an enzyme known as acetylcholine esterase. Okay. And these are then, I'm going to draw it again here. So you have your terminal here, and your acetylcholine molecules are here. These acetylcholine molecules are broken down into acetyl and choline, and these are now taken back up into the, so the acetyl is now taken back up, the choline is now taken back up into the presynapse, and then again converted into acetylcholine vesicles. Now there are two enzymes here. One is that there is acetylcholine esterase, which breaks down the acetylcholine into the two components, and inside the presynaptic membrane, there is a choline acetyl transferase. So there is another enzyme that puts them back together. Fine. So now we have covered step 1 and step 2. Now what happens in step 3? Step 3 is all about what happens when the acetylcholine attaches itself to the receptor. So if there is a receptor like this, and you have your acetylcholine molecule that has attached itself, what happens after that? This acetylcholine receptor will cause increased sodium entry. This sodium entry will then lead to something known as end plate potential, and this end plate potential will then lead to your calcium entry, and that will lead to muscle contraction. Now, for the sake of our discussion today, we only need to talk till here. We don't need to know what happens beyond this, because all of this comes under muscle physiology, which we can discuss on another day. But today, our main focus is what happens in this area. Okay, because this is the neuromuscular junction. So the 3 parts of the neuromuscular junction that we need to know is in step 1, electric signal, increase calcium entry, release of acetylcholine from the vesicles. Step 2, acetylcholine binding to the receptors and then getting broken down into acetyl and choline by acetylcholine esterase enzyme. And in step 3, your acetylcholine receptor leading to sodium entry and then ultimately leading to muscle contraction. And when then the acetylcholine is broken down, that choline gets reuptaken into the presynapse, and then acetylcholine is reformed. So this is the basic anatomy and physiology of your neuromuscular junction. Okay. Now coming to what can go wrong in your neuromuscular junction. So in the 3 parts of the neuromuscular junction, that is the presynapse, the synapse, and the postsynapse, in each part, something could go wrong. So just logically speaking, every step in this path can go wrong. So for example, your electric signal coming in may not come in for some reason. Then it would become a neuropathy. Your choline esterase enzyme, your choline acetyl transferase enzyme that creates your acetylcholine, there may be something wrong with that. There may be something wrong with the calcium entry. There may be something wrong with the acetylcholine release. There may be something wrong in the acetylcholine binding to the acetylcholine receptor. There may be something wrong with the acetylcholine getting broken down into acetyl and choline. And even in the post synapse, even if the acetylcholine receptor is activated, there may be something wrong in increasing the sodium entry and then ultimately a muscle contraction. So at every step, there may be something wrong. Out of all these things, myasthenia gravis is a problem with your acetylcholine receptor. So when we say myasthenia gravis, we mean that there is something wrong with this acetylcholine receptor, because of which these acetylcholine molecules are not able to bind to those receptors. That's it. That is what myasthenia gravis is. So in your neuromuscular pathology, when we talk about presynapse, synapse, and postsynapse, your myasthenia gravis comes under your postsynaptic problems because it is to do with your acetylcholine receptor. We will talk about the others at the end of the lecture, but right now, let us just start discussing about myasthenia. because out of all the neuromuscular junction disorders, myasthenia is the most important one. In myasthenia gravis, what happens? In myasthenia gravis, there is nothing wrong with your electric signal, nothing wrong with your acetylcholine release. Your molecules of acetylcholine are in the synapse and they are trying to connect to the acetylcholine receptor. But for some reason, they are unable to connect. And the reason for this is that there is something else that is already taking its place. So there is another molecule that has already taken its place. And so this acetylcholine is not able to bind to the acetylcholine receptor. And whatever this other thing is not creating any muscle contraction. So effectively what happens is that your body wants to move the muscle. So now let us imagine that you have your biceps muscle here and your musculocutaneous nerve is here. Now your body wants to move this muscle, but even though the signals are coming in from the brain to the neuromuscular junction and your muscle is also okay, you are not able to move it because your acetylcholine is not able to connect to the acetylcholine receptor. Why is it not able to connect? So what is this thing that is preventing your acetylcholine from joining into the acetylcholine receptor? So this is a antibody. So there is a lot of theory into what forms this antibody and why. One of the commonest theories is viral tropism. So there is an infection and your body's immune cells try to attack that infection, and there is a part of that infective molecule which resembles your acetylcholine, and so the uh, the antibodies acetylcholine receptor, and so the antibodies that form against it are now very similar to acetylcholine, so then they can come and fit into your receptors. The other theory is your uh, thymic lymphocytes. So in your body, there is an organ called as thymus, and your thymus is responsible for forming your T lymphocytes. And another theory is that it is this thymus that forms these lymphocytes and therefore these antibodies that will come and sit on your acetylcholine receptor. The reason we feel that is because myasthenia gravis has a lot of connection with thymoma. So for today's discussion, we won't go too deep into what creates those antibodies because I want to focus more on the clinical aspect of myasthenia. But roughly, these are the two main reasons why, the main two hypotheses as to why those antibodies are formed. So ultimately, there is an antibody that has now connected to the acetylcholine receptor, and that is now preventing your normal acetylcholine uh, to connect to the acetylcholine receptor. So then that will lead to decreased muscle contraction. And if there is decreased muscle contraction, there is weakness. So the main effect of acetylcholine receptor antibody, that is myasthenia gravis, is muscle weakness. Now, if you look at a myasthenia gravis patient clinically, where all can there be weakness? So it can technically be anywhere. So in every muscle in your body, you need acetylcholine receptors, every skeletal muscle. So all your voluntary muscles need acetylcholine, but so that is technically it can be in every muscle in your body, but there is a preponderance to your extraocular muscles, your bulbar muscles, so in your throat, and your proximal muscles, and sometimes your respiratory muscles. So these are the muscles that are more commonly involved in myasthenia. So depending on the sites of the lesions, you can have ocular myasthenia gravis, so involving the extraocular muscles. So you can have ptosis. So that is your eyelids are closing. So eyelids are covering the pupils, and you can have diplopia. And the reason you have diplopia is because if your muscles are, some of your extraocular muscles are weak. Now, if you remember from your extraocular movement discussion, we talked about how each of your extraocular muscles, so your superior rectus, inferior rectus, superior oblique, inferior oblique, lateral rectus, and medial rectus. So all of these muscles have to act together to keep your both your eyes parallel. Now, suppose in both your eyes, if one side, one muscle is weaker than the others, then they will no longer maintain that parallel gaze. So one of the eye will move more and the other eye will move less. So that can create a split image. So this is called as diplopia. So you can have ptosis and you can have diplopia. If your muscles in your throat and pharynx are involved, that can cause bulbar myasthenia. And if your body is involved, then that is known as generalized myasthenia. And you can also have generalized myasthenia with or without respiratory involvement. Okay. But the characteristic of this whole thing is weakness, because no acetylcholine binding, no acetylcholine receptor activation, so no muscle contraction. But there is a specific characteristic of this weakness, which is known as fluctuating weakness. Now, why is it fluctuating? And this is the crux of myasthenia gravis. This is the first question that you need to ask if you are suspecting a patient with myasthenia gravis. When will you suspect? Any patient with any of this. So any patient with ocular symptoms, bulbar symptoms, generalized weakness, or respiratory muscle weakness, you will think of myasthenia gravis. And if you think of myasthenia gravis, the one question you will ask is fluctuating weakness. So weakness that is sometimes present and then sometimes it gets better and then it again worsens. So that is a fluctuating weakness. Why does that happen? So the reason is that if you have a release of acetylcholine and you have n number of postsynaptic receptors, initially when you start activation, you can have say 100 acetylcholine molecules. So these 100 acetylcholine molecules may fill up all the acetylcholine receptors. But as you go on working, the number of acetylcholine molecules released will keep decreasing because there is a fixed amount of acetylcholine inside. And as they decrease, the acetylcholine available in your synapse is decreasing because even the ones that are there are also being broken down by acetylcholine esterase. Now, there are a lot of acetylcholine receptors which are empty, and these get occupied by your antibodies. So as you work, initially there will be no weakness. And as you keep working, your weakness will increase. This is called fatigability. So this is part of your fluctuations. So one part of the fluctuating weakness is fatigability. What is the other part? So suppose you wake up in the morning, you are well rested, your acetylcholine reserves are full. But as you work throughout the day, by evening, as you keep on working, your acetylcholine reserves get used up. And even though they are getting replenished, the rate of replenishment gets on getting lower and lower. So by evening, your acetylcholine reserve is less. So again, by evening, you have increased weakness. And this is known as diurnal variation. So diurnal variation is a circadian variation. So in the day, or when you wake up in the morning, there is no weakness or less weakness, but by evening, the weakness has increased. And this weakness can be anything. The weakness can be ocular. So you may have ptosis in the evening, but when you wake up, there is no ptosis. There's diplopia in the evening, but when you wake up, there's no diplopia. Similarly, bulbar weakness, generalized or respiratory involvement, all of these will become worse after exercise and by the end of the day. Okay. So these are the two characteristics of myasthenia gravis: fatigability and diurnal variation. What else? What other history will you take? Effect of treatment. So there we will discuss what is the treatment later, but there are medications that you can give that will improve the symptoms. But this improvement will be temporary. So whatever medication we are giving, ultimately the effect will be that your acetylcholine molecules will bind to the receptors more. And as soon as they bind more, your symptoms disappear. And as soon as they bind less, your symptoms reappear. So there is an inherent variability. So whenever we give a medication, the symptoms will disappear. And as the medication wears out, your symptoms will reappear. So the third characteristic of fluctuating weakness is fluctuating with treatment. So there is fatigability, that is fluctuation with exercise. There is diurnal variation, that is fluctuation with the time of the day. And there is medication induced fluctuation, so that is fluctuation because of the effect of medicines. Okay. So that completes your anatomy of the neuromuscular junction, the physiology of the neuromuscular junction, what happens in myasthenia gravis. There's an antibody against your acetylcholine receptor. And because of this, your acetylcholine is unable to bind to the receptor. And because it is unable to bind, you have weakness. That weakness can be in your eyes, which is ocular myasthenia, in your swallowing and in your speech, so that is bulbar myasthenia, in your limbs, which is predominantly your proximal limbs, so that is generalized myasthenia, and there can be respiratory involvement. And the characteristic of the weakness is that it is fluctuating. The fluctuation can be with exercise, which is fatigability, with time, so that is diurnal variation, and with treatment, so that is treatment induced variation. Now, Karthika just asked a question. Isn't this acetylcholine getting used up in normal patients also? Then why is this acetylcholine used up more in myasthenia patients? So in normal patients also it is getting used up, But in normal patients, there is more receptors available. Whereas in a myasthenia patient, there is less receptors available. So if suppose there are 8 receptors that are available in a normal person, and you have say 10 acetylcholine molecules that are released. Now there is nothing wrong with the release. So there are 10 molecules that are released in a normal person and 10 molecules released in a myasthenia gravis person. So let's take the normal person. In a normal person, you have 10 molecules. So 8 of those molecules will attach to the 8 receptors and 2 will be extra. And this attachment is also very transient. It is very temporary. It doesn't stay there. It attaches, it has its effect, and it gets detached. And then it again comes out, and that also gets lysed. So ultimately, all 10 will get split into acetyl and choline. But only difference is that 8 will have its effect. Now, what happens with the effect is that each one of these will cause sodium entry, and the effect of all the sodium entry is that your action potential has to cross a certain threshold. And if it crosses that threshold, then it will lead to your action potential. So the EPP has to cross a certain threshold, and then it will lead to action potential. So here in the action potential, it is an all or none. So if the EPP crosses this threshold, then there will be action potential. If the EPP doesn't cross the threshold, there will be no action potential. If there's no action potential, there is no muscle contraction. If there is action potential, there is muscle contraction. So for the action potential, it doesn't care how you reach that threshold as long as you reach it. But in order for the EPP to reach this threshold, I'll draw this as a graph. This is the threshold. If it crosses this threshold, then it leads to action potential. And it will cross this threshold only if there is sufficient sodium entry. Okay. Now, let us imagine that all 8 of these acetylcholine receptors are working fine. Now, all 8 will have an acetylcholine attached. All 8 will lead to sodium entry, and your EPP has crossed this threshold. So now there is an action potential and your muscle is contracting. Okay, cool. So this, I'll just add one more thing. So this part, this is known as the safety factor. So in a normal person, you are releasing a lot more acetylcholine than you need. So if you want to move your biceps and you need, say, for example, arbitrary, you need 10 acetylcholine molecules, your body is releasing 1,000 acetylcholine molecules because you don't want to take any risk. So even if you keep working, that 1,000 will become 500, that 500 will become 100, that 100 will become 50, but you need only 10. So your body has a huge safety factor to make sure that your muscles are always moving. But in a myasthenia patient, when there are less acetylcholine receptors, your safety factor becomes less. So when there are 1,000 acetylcholine molecules, there is a continuous supply of acetylcholine. But if that acetylcholine becomes less, suddenly all your acetylcholine receptors don't have acetylcholine anymore. So then you have weakness. But then if you rest for a while, your acetylcholine gets replenished in the presynaptic membrane. And so you again have enough acetylcholine to fill up the remaining receptors. So it is because your safety factor is decreased, which is why you have weakness, fatigable weakness. Now, let's talk about how common is it. So, how common is myasthenia gravis? So, it happens for around 1 in 1 lakh. The incidence is around 1 in 1 lakh, and it is overall, it is more common in females, especially in younger females. So, if it is like less than 40, females are more, and then as you grow older it sort of becomes the same. Male and female are both equally likely, but in younger patients, females are more likely to get involved, and there is a strong association with thymoma. Okay, now what is the prognosis of myasthenia gravis? Earlier it used to be quite bad. So it used to be that almost 30% of patients who were diagnosed with myasthenia gravis would not survive. They will die because of myasthenia gravis. But now, because of treatment, because of surgery, the mortality rate is less than 5%. So now it is not such a terrible disease to have as it used to be, but it is very, very important for diagnosis. So if you don't diagnose, you can't treat. And myasthenia gravis is something that can be missed. So, and it is a big crime to miss myasthenia gravis because it is so treatable now. And if you start treatment in time, the prognosis is quite good. Now, out of myasthenia, the different types, all the myasthenia gravis is not equally risky. So your ocular myasthenia is the safest. Then you have your generalized, then bulbar, and your respiratory involvement. So if there is respiratory involvement, obviously that is dangerous. And bulbar is also dangerous because there is risk of aspiration. So when you're trying to swallow, the food particles or the water may not go into your stomach, it may end up in your lungs. So then you can have aspiration pneumonia. So that is why different types of myasthenia has to be taken with different seriousness. If you are suspecting a case of myasthenia, how do you diagnose it? First is clinically. And in clinically, you have to take history and you have to examine. And in history taking, the idea is that you ask for, you have to localize. So where, what, and why. So in the where, you have to localize the lesion to a neuromuscular junction, first of all. So that means basically ruling out the rest of your neuroanatomy. So is it in the brain? Is it in the spinal cord? Is it in the nerves? Usually everywhere else, there will be some sensory involvement as well. But a myasthenia gravis patient, there is pure motor. So whenever you say pure motor, you are likely to be dealing with a case of neuromuscular junction or a myopathy. And the difference between these two is that both of them will have weakness, but neuromuscular junction will have fluctuating weakness. And a myopathy is not likely to have a fluctuating weakness. There are specific kinds of myopathy that do have fluctuating weakness, but overall, fluctuating weakness means neuromuscular junction. Then in examination, you will examine the same areas, your ocular, your bulbar, your proximal muscles, and respiratory, and you will see if there is fatigable weakness or not. Now, how do you test for fatigable weakness? It's very simple. You make the patient exercise. So before and after that muscle exercise, you check for weakness. So in the eyes, you ask the patient to look up. And eventually, after 1 minute, 2 minutes, 3 minutes, there will be gradual weakness of your superior rectus muscles. And then and there will also be gradual weakness of your eyelids. So if you're continuously looking up, your the eyelid muscles are acting, and gradually there will be weakness and there will be drooping of your eyelids, which is called ptosis. You can also make the patient abduct the arms, like keep the arms abducted for 1 minute, 2 minutes, 3 minutes. This is called as arm abduction test. And eventually, because of your abductor weakness, the arms will start to fall down because these are continuously working. So your acetylcholine is acting, and then gradually, as your acetylcholine level drops, there will be more and more and more weakness, and then your arms will drop. So you count the time as to how long he can hold up. And finally, you have your pharmacological tests. So you can have a neostigmine test. So basically, your neostigmine test is a test in which you check for muscle weakness, and then you check for improvement in your muscle weakness after you give neostigmine. So now let's talk about what is neostigmine. So neostigmine is a type of anticholinesterase. So we spoke about acetylcholinesterase. So in your neuromuscular junction, your acetylcholine molecules are broken down by your acetylcholine esterase enzyme. And because they're broken down, your level of acetylcholine decreases. Now, suppose there was some way for us to block acetylcholine esterase. So if you block acetylcholine esterase, your acetylcholine will not be broken down. So there will be more acetylcholine available in the synapse. And if there is more acetylcholine available, then you have more molecules that are available to fill in the acetylcholine receptors. So anything that can block your acetylcholine esterase is a helpful drug to give in myasthenia. And this class of drug is known as acetylcholine esterases. And the main ones that we use is neostigmine and pyridostigmine. So neostigmine we can give as an injectable, and that is what we use in this test. You give neostigmine injection, 1.5 milligram IM, and you test the patient before, and then you test the patient after you give this injection, and you check for improvement. So if it is a problem with your acetylcholine receptor, then your neostigmine should cause improvement in the clinical findings. Okay. And finally, you have your antibody tests. Now, I told you how in the postsynapse, your acetylcholine receptors are being blocked by these antibodies. So what we can do is we can check for the serum level of acetylcholine receptor antibody. And if this is coming very high, then that is a sign that it is myasthenia gravis. So that is the clinical approach, the evaluation. And finally, in evaluation, there is also an electrophysiological test, which is called as repetitive nerve stimulation test, RNST. And roughly in this, what you do is you check for weakness. So you check for your nerve stimulus, and then you check how much is the muscle contracting, and then you repetitively stimulate this nerve again and again. And as you repetitively stimulate, what will happen is that you are actually depleting your acetylcholine. And as your acetylcholine becomes lesser and lesser, your contraction should become lesser and lesser. And if this does decrease, then it means that there is something wrong in your receptor level. So then you can prove that it is a case of myasthenia gravis. And coming to management, the most important part of management is the diagnosis. So once you diagnose, then you can go ahead with it. And the two main forms of management is pharmacologically, it is your anticholinesterases, so pyridostigmine and neostigmine, and you also have your immunomodulation. So in immunomodulation, you have steroids and long-term immunosuppression. So long-term immunosuppression is your uh, secondary immunosuppressants such as azathioprine or cyclophosphamide or mycophenolate mofetil. So cyclophosphamide is not commonly used, but azathioprine and mycophenolate mofetil are the drugs that are commonly used for long-term immunosuppression. And there is also short-term immunomodulation, which is plasma exchange and IVIG. So what these plasma exchange and IVIG, what they do is they remove these antibodies that are on top of the acetylcholine receptor. They come and remove it. And because they remove it, now these receptors are now free to accept the acetylcholine molecules. What are the other kinds of neuromuscular junction disorders? So one is your presynapse, other is the synapse, and third is postsynapse. Myasthenia gravis was the main example of your postsynaptic membrane problem. What are the things that can happen in your presynapse and your synapse? So now let's go back to our first diagram where we discussed what are the things that can go wrong. Now, we said that there could be something wrong with your choline acetyl transferase, which forms the acetylcholine. So that is one. There could be something wrong with your calcium entry into the presynapse. So that is two. There could be something wrong with your acetylcholine release, which is three. Now, there are two main forms of neuromuscular junction disorders that I want you to remember. One is apart from myasthenia gravis. So the first one is, of course, myasthenia gravis. The second one is something called as LEMS, which is Lambert-Eaton myasthenic syndrome. And the third one is congenital myasthenia, congenital myasthenic syndromes. And all of them, myasthenia gravis, LEMS, and all the congenital myasthenic syndromes. So there are a lot of them. There are around 8 to 10 of them. All of them will ultimately cause some problem in this pathway. Okay. So there will be some defect in this whole pathway that will ultimately lead to decreased muscle contraction. So myasthenia gravis is just involvement of your acetylcholine receptor. What about LEMS? What does LEMS do? In LEMS, there is a problem with your calcium entry. So there is a calcium channel that lets calcium enter the presynapse. And if there is a problem with this calcium channel, then your calcium cannot enter. If your calcium cannot enter, then your acetylcholine will not get released. So what can cause the calcium channel to get, for there to be a problem with the calcium channel? If there is in LEMS, it is a paraneoplastic antibody disease. So if there is a cancer in your body, that cancer can lead to antibody formation. And in LEMS, that antibody acts against this calcium channel, specifically the P by Q subtype of calcium channel, and it will block this calcium channel. And if this calcium channel is blocked, it will lead to decreased acetylcholine and ultimately decreased muscle contraction. That is one. And everything else comes under your congenital myasthenic syndromes. So if there is a deficiency of your choline acetyltransferase, if there's a deficiency in your acetylcholine esterase, if there is any other problem in your acetylcholine receptor itself, not an antibody, but if there's a problem in your acetylcholine receptor itself, or there are a lot of other proteins that have a role in keeping this acetylcholine receptor attached to the postsynaptic membrane. So if there is a problem in any of these proteins, it will ultimately lead to a problem in your action potential. So I'm not going to go too deeply into congenital myasthenia syndromes, but just remember that you have presynaptic congenital myasthenia, which is choline acetyltransferase deficiency. You have a synaptic congenital myasthenia, which is a mutation in your acetylcholinesterase enzyme. And there is postsynaptic congenital myasthenia syndrome, in which there is a congenital problem in your receptor itself or in any of the proteins that keep the receptor in place. So there are 4-5 of them. Okay, so there's DOX7, there's Rapsin, there are multiple of them, and all of them perform slightly different functions, but the ultimate role is to keep the receptor in place. Okay, so any of the problems will lead to decreased action potential. So that covers your neuromuscular junction and your myasthenia gravis. So the effect of your other myasthenic syndromes will be the same. There will still be weakness. All of them will cause some form of generalized weakness or bulbar weakness or ocular weakness, but with some variations. So some of the congenital myasthenic syndromes will cause ocular weakness. Some of them will not. Some of them will cause bulbar weakness. Some will not. Your LEMS will not cause your ocular weakness so much, but it may cause autonomic symptoms. So there are some variations, but this is the basic approach. Okay, bye guys, take care.